The heart is one of the most important organs in the body, working relentlessly to enable the human cardiovascular system to function. The heart has four chambers, the upper right and left atria, and the lower left and right ventricles. In a healthy heart, blood flows in one direction through the heart's chambers. Delicate tissue-like structures called valves function to ensure unidirectional blood flow within. The heart has four such valves, which regulate direction of the blood flow. The mitral valve separates the left atrium from the left ventricle and is made up of two thin flexible flaps called leaflets. When freshly oxygenated blood from the lungs returns to the heart, it enters the heart through the left atrium. Left atrium relaxation causes the mitral valve to open, enabling blood to travel into the left ventricle. When the left ventricle contracts, the mitral valve closes to prevent backflow. In some people, the mitral valve doesn't close tightly, causing mitral valve regurgitation. When the heart beats during contraction, the blood from the left ventricle can flow back up to the left atrium. Mitral regurgitation, MR, can be subdivided into functional and degenerative subtypes. Degenerative MR, or primary, results from anatomical abnormalities of the valve itself. In most cases, the chordae connecting the mitral valve to the papillary muscle rupture or elongate, causing leaflet prolapse. MR is a progressive disease which, if left untreated, can initiate a series of events culminating in heart failure and death. Current guidelines recommend surgical mitral valve repair or replacement in severe MR patients. For MR patients for whom surgery is not an option, minimally invasive procedures are available. MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach and transseptal puncture to gain access to the left atrium. MitraClip's steerable guide catheter is introduced over a previously placed guide wire. The dilator is used to gradually advance the guide into the left atrium, and the guide wire and dilator removed. The clip delivery system is advanced into the left atrium, positioning the clip above the regurgitant jet and perpendicular to the mitral valve plane. Inside the left atrium, the clip arms are open to 180 degrees and positioned perpendicular to the line of coaptation before crossing into the left ventricle. The clip is advanced into the left ventricle below the valve leaflets and retracted to grasp the leaflets. MitraClip grippers are designed to drop firmly into the clip arms, securely capturing both leaflets. Once the arms are closed, they create a double orifice within the mitral valve. Prior to clip deployment, echocardiographic imaging is used to assess procedural efficiency and leaflet capture. Prior to deployment, the MitraClip can be released and repositioned for optimal MR reduction. Once achieved, the clip is released and the full system retracted. In most cases, the transseptal puncture reseals itself and tissue ingrowth between the clip arms increases, facilitated by the polyester clip covering, which promotes healing to create a fibrous tissue bridge between the leaflets. The MitraClip procedure is a minimally invasive, highly effective treatment option for select patients with severe MR.
Hello, my name is Manny Barbosa and I'm an ICU nurse educator. So I'm here to share you information about how are you going to care for patient post MitraClip procedure. Sometimes it's really hard to find some information. What do you really need to look for? And so I decided to share this to you guys because I've been an ICU nurse for 30 years and I have seen how new nurses struggle in the ICU because either the lack of exposure and lack of experience being novice in the ICU setting. So if you're that nurse who might need information about what you need to do with this type of patient, then this is for you. Or if you've been an ICU nurse for a while and you're a little bit confused what do you need to look for, and when do you call the doctor. This is also for you. Okay, so the background. We all know mitral valve is the second most common acquired valvular heart disease in adults, meaning any related condition related to mitral valve, like mitral valve regurgitation or stenosis. So sometimes they're going to be managed medically, but sometimes they do go for surgical intervention. And I'm glad that we have the MitraClip now, because you don't have to open the patient, just to repair their mitral regurgitation. And so what happened is there's a flail or billowing leaflets from prolapse are the most common pathologies amenable to resection or repair. So that's why you need to clip it. And it reduces mortality, reduces endocarditis, any kind of complication like stroke, and they can go home in a day or two, depending on the recovery. So this is how it looks like, the MitraClip. Actually, the Menlo Park is so close at the VA Palo Alto. So what do you need to do and to know? Post-procedure, sometimes this patient will go home, and if they're not taking any antiplatelet therapy, so now they're going to take it for 6 months, and they will reevaluate if the patient still needs it, and if not, then probably they will discontinue it. However, it's highly recommended if they're going to go for any oral surgery or procedure or urology procedure, then they need to let their doctor know about that, because they're going to get prescription for prophylaxis for infective endocarditis. Alright, so if they have underlying AFib or thromboembolic venous disease, then of course they will continue their Coumadin. This is the data that actually I got from research, some articles that actually publish the MitraClip. And it's showing here, and this was, I believe, many years ago when they first came out. After 2 years, they made some study. And death, when the patient goes for surgery, the tendency is complication. Mortality rate is 16.2, and compared to MitraClip, 3.3. Bleeding is what we always think in surgical patient, 59%, and you only have 4.2 when you do your MitraClip. So what do you need to do? What do you need to know? Well, if I'm a nurse taking care of this patient, I should know the following. Respiration, check your patient's respiratory status for short of breath. Pneumothorax, after they inserted the central line, you have to do a chest x-ray to confirm that there's no pneumo before you use your central line. Usually I normally ask the doctor, did you order for chest x-ray? And if not, you can always ask the doctor. Heart failure, pulmonary edema. Again, this is something new. If this is something new, check your patient for, activity intolerance, coughing, and expectorating, some frothy blood-tinged sputum. And so what you need to do is monitor vital signs, including respiratory rate and chest wall expansion. So when I say chest wall expansion, you have to make sure that the patient can able to take a deep breath without guarding or holding their chest as if it's, they're having pain. And what do you want with your pulse ox? So do you have an adequate O2 saturation? And if you do, you don't have to worry about it. However, if your patient has been desaturating to like 88 and the highest O2 sat is 92, I would probably call the doctor and inform them just to make sure that they're aware. And you have to observe your patient for cyanosis, any, temperature, skin temperature. Is it warm? Is it cold? And any signs of perfusion, just like your nail beds. Okay. Administer oxygen as prescribed. Okay, to keep your O2 sats at the desired level, 95% sometimes it's okay. Or better yet, you want it higher. And notify the doctor. What about your neurological status? So patients LOC, are they alert, awake, oriented, or are they disoriented? So you have to monitor that and record it. Make sure that you check your movements, your bilateral arm movement, speech is clear. So what you're really looking for here is signs of stroke. And if you do find one, you have to call the doctor. Also, check for pupillary reaction, pupil sizes, okay? Because if that's an abnormal and it's acute changes, that's something that I want you to call the doctor. What about your cardiac monitoring? Of course, you put them on a monitor and make sure that you check the monitor frequently for any kind of changes. If they're sinus rhythm and now they're AFib, you need to call the doctor. If they're throwing a lot of PBCs, check their electrolytes. If your magnesium or potassium is low, then you have to replace the magnesium first and then you give your potassium. And you do your 12 lead EKG before and after the procedure and also daily until they go home. Again, for any kind of abnormalities, you have to call the doctor. So you have to make sure you assess their cardiac rhythm for any arrhythmias. What about hemodynamics monitoring? So you need to, if the patient has an art line, connect the art line to your monitor. And if the patient has a CBP, I would connect them. CBP can actually give you, the tracing of your CBP can actually give you an idea if the patient is going for cardiac tamponade, as you might lose your Y descent and it gives you a very sharp X descent. So which means that if you don't see that ACV, and if you see like AC and then V and then A again, so that means it's just going to give you an indication that there is a fluid overload into the right side, okay, because the heart is not really able to pump. So that's a cardiac tamponade. Again, cardiac tamponade comes with sinus tachycardia or tachycardia. If they're allergic to anesthesia, you have to check, you have to monitor them for any allergic reaction. Continuous vital signs, including your art line, BP via art line, and as I mentioned, your heart rate and rhythm, and notify the doctor. Okay, just FYI, not all cardiac tamponade are, good candidate for pericardiocentesis because they might bleed more. So nursing care plan again, your access site. So normally the port of entry or the insertion site here is via the venous. They go to the venous ephemeral into the right atrium and then they will poke the septum going to the left atrium, just like the Watchman procedure, and then it goes down to the mitral valve and they will deploy the clip. So you will expect your patient to get bruising, pain, and the insertion site or the puncture site. You also check for limb ischemia, so check for pulses, the dorsalis pedis, or the posterior tibialis. So check that. And how do you know if they're bleeding internally? Retroperitoneal bleed. Check your heart rate. Usually the heart rate goes up faster, blood pressure is dropping. And if that's the case, and if you don't see any hematoma anywhere, then check for H&H. You might have a drop on your hemoglobin and hematocrit from your baseline. Then call the doctor. Or sometimes they call the doctor and then they order for H&H. But it all depends on your institution. Some hospitals, they do first. They do everything lab, draw, and then once they get the result, that's when they call the doctor so that it's all in one. information. You use your S bar. What's your situation, your background, your assessment, and what would you recommend? So direct observation on the site, you have to palpate, you have to check and compare to the other side. And this is what we call groin management. And then you notify the doctor for any kind of abnormalities. If they're gonna come out with suture, again, it's all depending on your policy. Are you allowed to remove the suture, or the doctor will remove the suture? So this is something that I would highly recommend that you know what's covering your scope of practice. What about chest pain? Patient might have a chest pain. If the patient complains of chest pain to you, it could be an MI, angina, cardiac tamponade, or basically bleeding and now leading it to anemia. So potential and possible problem. So you do your assessment. You pain assessment using your whatever tool you guys are using in the ICU. Usually CPOT or pain, word or verbal, like the 0 to 10 pain scale. And then you have to record the EKG and vital signs and report for any abnormalities. Again, if you have to do an echocardiogram, you have to call the technician to have it done as soon as possible before the doctor gets there. And of course, you check the H&H for any possible bleeding. What about pain? So you have to manage the pain, because imagine some of your patients probably have a pain tolerance, very low threshold. It can have a lot of discomfort on the groin. So assess the patient using your pain assessment tool. Give them pain medication. Be very careful not to drop their blood pressure too much, and observe for the site for abnormalities. And you need to ask or help them to reposition as needed. You notify the doctor for any abnormalities and assist them for what they need. Sometimes you might tell them a part of the groin management, especially if they just came out, keep the legs straight, or they sometimes have PEM stop and they can't move. So you have to help them out, shift their position and give them what they want. Sometimes some of the hospitals don't want to feed the patient until everything gets better or stable. What about infection, endocarditis, potential in problem for on the insertion site? So that's something that I want you guys to observe. Record your temperature. Make sure that you compare it from the baseline. That's why I always ask you to get your baseline vital signs, making sure that you don't have fever. Patient doesn't have a fever. If the patient have fever, then you have to call the doctor. Ensure hand washing as your protocol. You can give them the IV or oral antibiotics as soon as possible as ordered. And of course, you have to check your labs for WBC, any inflammatory markers. Urinary catheter, infection and impaired kidney function. So again, depending on what they use during procedure, the doctor is usually going to give you some information. If they use too much contrast, then of course, you have to protect the kidney from being damaged. So clean your catheter, Foley care. Ensure the position of the drainage bag. What we always say, it's above the floor, not on the floor, but below the patient's bladder. You need to do your monitor INOs and document and make sure it's accurate. And of course, check your chemistry, BUN, and creatinine. Central venous catheter, if you have one, make sure you do your sterile technique in dressing, changing the dressing as needed. Don't touch it too much when it's falling, because patient is sweating, or they have a very oily skin. oily skin and then your dressing is peeling off, so make sure you have to reinforce that. Do it aseptic technique, observe site for bleeding or oozing, and document. And I think that's all I have for you guys. So if you guys have any question, please check it with your nurse educator. This is something that we do at my hospital, and I'm just sharing it with you guys. Thank you.